Hello guys, this is Vikrant and Sengar, pursuing MBBS from GRMC Gwalior, now presenting the last disease of GIT section, and hence we have achieved the first milestone of the integrated medicos. So let's get started. So guys, I have posted my notes on my Instagram account, that is the integrated medicos. Do check it out. But now we will go for part 3 of IBD, and we have covered the part 1 in which we have dealt with the anatomy, followed by etiopathogenesis, clinical features and the complications of IBD, and subsequently in the part 2 we have also discussed the diagnosis, and now we will go for the treatment portion, right? And first we will go for the drug classification, subsequently the individual drugs, right, and then the medical management and the surgical management as well. So have a look. So now guys, we will discuss the drug classification of IBD. Number 1 is the 5-ASA agent, that is the 5-amino salicylic acid agents, including the sulfasalazine, mesalamine, olsalazine and the balsalazide. And subsequently we have the cyclosporine, and then the antibiotic group having metronidazole and the ciprofloxacin, right? And subsequently we have the steroid group of drugs in which the prednisone, prednisolone, hydrocortisone and the budesonide is there, right? And then we have the tacrolimus, and subsequently we have the IMMUNO-MODULATORS in which the azathioprine and 6-mercaptopurine are the examples of that. And then the anti-TNF alpha group in which the infliximab is there, and subsequently adalimumab and certolizumab pegol and the golimumab are the examples of that. And subsequently we have the methotrexate and the anti-integrins in which natalizumab and the vedolizumab are the funny examples of that. So guys, now we will go for the individual drugs. The first drug is the 5-amino salicylic acid agents here. Okay, so mechanism of action is, number 1 is the NF-kappa beta inhibition, right? And once this molecule is getting inhibited, there is the down regulation of production of cytokines, and once cytokines are lesser, there is decrease in inflammation, right? So second mechanism is the PG synthesis inhibition, right? And once the PG, the prostaglandins are lesser, there is lesser risk of getting the inflammation here. So that is what the mechanism of 5-ASA agents, and now uses, and that is mainstay of therapy which is given for the UC and the CD. So that is what the indications, and subsequently we have the side effects of that, and that is the abdominal pain, nausea and vomiting, and then headache and fever and the skin rashes, right? And now we will go for the non-specific side effects of drugs which are involved in the IBD, right? So we have 3 system involvements, that is the skin involvement, subsequently the CNS involvement, and third thing is the GIT involvement. The most common side effect with respect to skin is the skin rashes, right? And then there is risk of getting itching here, right, and acne. Okay, these are non-specific side effects associated with entire drugs which will be discussed by us in the IBD section here, and subsequently the CNS involvement, right, in which the headache is more common here, headache and the drowsiness, right? And when the GIT is there, there is increased risk of getting the nausea and vomiting, anorexia and diarrhea, right? So these are non-specific side effects with respect to the GIT, CNS and the skin, right? So this is what the whole picture of side effects. And now we will switch to the next drug, that is the antibiotic, that is the metronidazole and the ciprofloxacin, right? And the mechanism of metro is, there is the formation of nitroso radicals, right, and thereby causing the DNA destruction here. That is the first mechanism of metro, and subsequently that is also giving the anti-inflammatory effect here. And third effect is the immunosuppressant action here. So we have 3 mechanisms with respect to metro, and now the uses including the fistulous Crohn's disease and the perianal disease of Crohn's disease here, right? That is what the indication. And now the non-specific side effects, that is the nausea and vomiting, diarrhea, fever, headache, dizziness and the metallic taste as well. So these are what the side effects. And now we will go for the Cipro, and the mechanism is, that is the DNA gyrase inhibitor, right, thereby causing the bactericidal action, right, and that is used in the case of pouchitis. that is one of the complications of UC after surgery, right? So this is what the indication, and these are also the non-specific, such as the nausea and vomiting, stomach pain, heartburn, rashes, and the headache and the tendinitis is specific here. And now we will go for the same thing for cyclosporine here, right? The mechanism of cyclosporine is that is the calcineurin inhibitor. Okay, and once the calcineurin is inhibited, there is decrease in the immune response, right? And the activation of naive T helper cell is inhibited. That's why the immune response will not occur, and that is what is achieved with the help of the cyclosporine here. And now we will go for the indication of cyclosporine. Number one is the severe category of UC, right? And that is given at the severe category of UC. And in the case of severe category of the UC, we need to give the cyclosporine IV and then the cyclosporine orally, right? But these are given in the case of severe cases of UC here, and we are not supposed to provide the cyclosporine to the mild or moderate patient of UC, right? So this is what the indication. And now we will switch to the side effects of the cyclosporine, and that is increase in the BP, increase in the hair growth, and the swollen gums are there. So this is what the side effects with respect to the cyclosporine is there. And now we will switch to next category. And next category is the glucocorticoids. And before we discuss the mechanism of glucocorticoids, now we will go for the synthesis of the PGs and leukotrienes, right? So first thing is the membrane phospholipids there, right? And this is getting converted into the arachidonic acid with the help of an enzyme, that is the phospholipase A2, that is the enzyme, and resulting into the formation of arachidonic acid, right? And this is converted into the PGG2 or H2, right? And this is done with the help of the cyclooxygenase enzyme, right? And subsequently this is converted into the PGE2, F2 alpha, D2, I2, and next is the thromboxane A2. And we need to provide different drugs in order to stop this pathway. So number one is the stoppage of phospholipase A2. Okay, so this is getting inhibited with the steroid intake. So that is what the steroid intake. And next is the cyclooxygenase enzyme, and that is getting inhibited with the help of the NSAIDs. So NSAIDs are just given for the blockage of this and inhibition of this enzyme, so that the prostaglandins and thromboxanes are not being produced here, right? So that is the basic picture, right? And now we will switch to the mechanism of the steroids here. Number one is the same thing that we have discussed right now, that is the PGLD inhibition, synthesis inhibition, number one. Second thing is there is the inhibition and down regulation of growth factor production. And third mechanism is there is down regulation of adhesion molecules, so that the neutrophilic infiltration and recruitment is inhibited here. So that is what the mechanism, and subsequently the uses, right? And that is solely used in the case of induction. Okay, so in the case of induction of remission, that is given in the case of CD and UC, both the conditions that is given, but only in the case of induction, not in the maintenance, since that is having massive side effects associated. That's why we need to provide it in the case of induction only. So what are the side effects of that? So side effects including are the weight gain, number one, subsequently the water retention, and then the blurred vision and the stomach irritation is there, and then the osteoporosis and the hyperglycemia are the worst side effects with respect to the steroid intake. That's why we need to provide the steroids only for induction, not for the maintenance purpose. So guys, next category is the tacrolimus. Okay, and the mechanism of tacrolimus is as same as that of cyclosporine, that is the inhibition of the calcineurin. And once the calcineurin is inhibited, there is the down regulation of immune response, and immune response won't come. That's why that is working as anti-inflammatory and the immunosuppressant. Okay, so this is what the mechanism of tacrolimus, and the uses including the steroid dependent and refractory CD or UC, right? So this is what the indication of tacrolimus, and that is rarely used here. So now we will discuss the anti-TNF alpha therapy, in which the drugs are supposed to bind and inhibit the TNF alpha molecules. That's why the anti-inflammatory activity and the immunosuppressive action is achieved with it. An indication of anti-TNF alpha therapy is the moderate to severe Crohn's disease, right? And the specific point is the certolizumab pegol is just given in the case of CD, and the golimumab is just given in the case of UC, right? While the adalimumab and the infliximab are just given in the both the conditions. These are the UC and the CD, right? But in the case of these two drugs, this is the specific indications which are respectively here. And side effects of anti-TNF alpha therapy is the lymphoma formation, and then the infections, the secondary infections may develop, and subsequently the lupus-like syndromes in which the multiple edematous patches will be there, and the joints involvement arthritis will be there as well, and can be the congestive heart failure as well. Okay, this is what. So next category of drug is the immunomodulators, in which the azathioprine and 6-mercaptopurines are the examples, right? And the mechanism is that is causing the inhibition of the purine synthesis, and once the purines are inhibited, right, there is decrease in the formation of DNA and RNA, and that's why the proliferation of the T cells, the lymphocytes will be decreased, and that's causing the decreased immune response and decreased inflammation. So this is what the mechanism. So now we will discuss the indications of immunomodulators. Okay, the first indication is the maintenance therapy of UC and CD. Second is that is used in the case of the perianal disease with respect to the Crohn's disease here, right? And the side effects including the same non-specific side effects. These are the abdominal pain, nausea, vomiting, anorexia, diarrhea, and the mouth ulcers and the headache. And these all are the non-specific symptoms are associated with any of the drugs, right? The next category of drug is the methotrexate, and that is inhibiting one enzyme, that is the dihydrofolate reductase, right? And this enzyme is needed for the conversion of dihydrofolate to the tetrahydrofolate, and once this enzyme is inhibited, there is decrease in the tetrahydrofolate, right? And once it is decreased, there is decrease in the DNA production, and the cell proliferation, the WBC proliferation is hampered here. Okay, and that is what is needed in the case of the IBD, right? And this is what the mechanism. And now the indication is that is used in the case of induction and maintenance of remissions of IBD, and that is used in the case of the CD and the UC, and that is mainstay in the therapy of the inflammatory bowel disease here. And the side effects are non-specific, such as the nausea and vomiting, fever, headache, diarrhea, and the rashes, and the hair loss, alopecia, right? And these are what the non-specific side effects. And next category is the anti-integrins, right? And once there is the inhibition of integrin molecules over WBCs, there is decrease in the extravasation, recruitment of WBCs. And what is the use of that? That is used in the case of the induction and maintenance of the remissions in the case of IBD, and that is a mainstay of therapy as well. And the side effects are the arthralgia, nausea and vomiting, headache, and nasopharyngitis, and these all are the non-specific side effects with respect to this drug. So now guys, we will discuss the medical management of Crohn's disease first, right? And first thing is the patient is presented with the acute illness, and that's why we need to provide the induction of remission, and subsequently we need to shift the patient to the maintenance of remission here, right? Remission is the recovery from the illness, right? And first thing is the induction. So in the case of the induction, we need to provide the strong drug in order to control his symptoms, and then we need to shift the patient to the maintenance therapy, in which we provide the drug for the long period of time, and the drug is having the lesser side effects. Okay, the preferred drugs are just given for the maintenance therapy, right? So first thing is the mild to moderate case of Crohn's disease, and first thing is we need to go for the induction of acute illness, right? So we need to provide the strong drug, that is the steroid, that is the budesonide, and we need to provide 9 mg OD once a day, right? And subsequently we need to shift the patient to the maintenance therapy, and we need to provide the drug with a lesser side effect for the long period of time, and most preferred drug is the 5-ASA, basically mesalamine. Okay, so mesalamine is just given for that, right? And if the patient is getting refractory, or if the patient is relapsed, and that's why we need to again go for the induction of active case, and we need to provide the steroid again in the case of the prednisone orally. And once the patient is having some relief from the steroids, we need to shift the patient to the maintenance therapy, and we need to provide the azathioprine or 6-mercaptopurine, right? And we can add methotrexate here, right? So this is what the maintenance. And if the patient is having moderate to severe CD, then we need to provide the induction therapy to the active case, that is the 6-mercaptopurine or the azathioprine or the methotrexate plus the oral steroids or the anti-TNF alpha therapy. So we need to provide two drugs. Number one is the immunomodulators and second is the steroid slash anti-TNF alpha therapy. Right. So we need to provide two drugs here. And once patient is achieving somewhat relief here, we need to shift the patient to the maintenance therapy such as the azathioprine plus 6 mp and added by the low dose of methotrexate here. And if the patient is suddenly relapsed, we need to provide the induction with the IV steroids plus the anti-TNF alpha therapy, right? And we need to shift the patient again to the maintenance therapy with the anti-TNF alpha therapy, right? And if the patient is again and again relapsing, then we need to shift patient to the total parenteral nutrition here. And guys, we have discussed the medical management of CD and now we will go for the medical management of the UC here, right? And first thing is the mild to moderate category of UC. First thing is the induction of therapy to the active case and we need to provide the 5-ASA. Okay, and mesalamine is preferred here orally or rectally, okay, can be given here. And once patient is having relief, we need to shift the patient to the maintenance therapy, that is the 5-ASA alone orally. And if the patient is relapsed, we need to provide the induction therapy again with the 5-ASA plus the oral steroids here, right? And this is what, and once patient is relieved, we need to shift the patient to the maintenance therapy with the low dose of 5-ASA. Along with this, we need to provide the immunomodulators, right? Okay, that is the plus sign here. And if the patient is relapsed again, we need to provide IV steroids. Along with this, we need to provide the IV anti-TNF or the IV cyclosporine is there, right? And once the patient is having somewhat relief, we need to shift to the maintenance therapy. We need to provide oral cyclosporine or oral anti-TNF alpha therapy such as infliximab. Okay, this is what the medical management of CD, right? And now we will go for the surgical management of CD and UC here. And now guys, we will discuss the surgery in the case of CD and UC. And before we discuss the procedures, we will go for the indications of surgery, right? So in the case of CD, we have the small intestine indications and the large intestine indications with respect to the surgery in the case of CD, right? So first is the stricture or abscess formation, right? Then we need to go for surgery. Second is the obstruction, the gut wall obstruction because of the adhesions. The indication is the massive hemorrhage, the hematochezia, the massive flow of blood, massive blood loss is the indication for that, right? And in the case of the indication of large intestine, first is the perianal disease. So in the case of the perianal fissure, perianal fistula, we need to go for surgery. Second is the colonic obstruction because of the adhesions, and third thing is if there is presence of colonic dysplasia. So these are what the indications, and now we will go for the procedures of surgery. So first thing is the TPC, that is the total proctocolectomy, right? So what is that? Okay, so this is what our cecum, ascending colon, transverse colon, and that is our descending colon, sigmoid colon, that is our rectum, and this is our anal canal here, and this is our terminal portion of ileum here, right? So what is our total proctocolectomy, right? There is the removal of entire cecum, colon, sigmoid colon, and the entire portion of rectum. So entire portion is removed. Okay, that is called as the total proctocolectomy. So what is left? The terminal portion of ileum and the anal canal is left, and we need to join them. We need to anastomose them, and resulting into the formation of the artificial rectum is there. Okay, so we need to produce the artificial rectum with the help of the terminal ileum, and we have three different approaches. First is the S-shaped, second is J-shaped, third is W-shaped pouch formation. So we need to form a pouch from this terminal portion of ileum, and then the anastomose this pouch, the ileal pouch, to the anal canal, and resulting into the formation of outflow tract with the pouch that is working as the artificial rectum here. Okay, so we have three types of pouch: S-shaped, J-shaped, and W-shaped pouches, right? And now we will discuss how to make a pouch. So this is what the terminal portion of ileum here, right? And we need to curve in the form of S-shaped loop here, right? So this is our S-shaped terminal ileum here, right? And this is our anal canal, that is most common type of anastomosis and pouch formation. Okay, and now this terminal portion of ileum is converted into S-shaped pouch, and this S-shaped pouch is getting anastomosed with the anal canal, and that is called as the ileal pouch anal anastomosis, right? So we need to anastomose both these things here. So the whole procedure is called as the total proctocolectomy with the ileal pouch anal anastomosis. So what are the indications of this, right? And if it is functional, then only we can perform this surgery, right? So the sphincter present here, it should be functional here. So the fecal incontinence should not be present. Okay, so there should be the functional anal sphincter should be there. That is the first indication of surgery here. And second is we can perform it into the adults here, right? These are what the indications. And second is the total proctocolectomy with the end ileostomy, right? So that is our terminal portion of ileum here, okay, and that is our anal canal here, and this is our terminal portion of ileum, and that is our anterior abdominal wall, and this portion is called as the right iliac fossa. And if this terminal portion of ileum is opened at the right iliac fossa over the anterior abdominal wall, that is called as the end ileostomy, right? And that's why that is called as the total proctocolectomy with the end ileostomy procedure here. And that is done in the case of the patients having the fecal incontinence and the older patients here. So patients are older and with the fecal incontinence, right? And third thing is the total proctocolectomy plus mucosectomy with the hand sewn ileal pouch anal anastomosis, right? So we need to go for the same procedure as the first one. So that is our ileal pouch formation, right? That is our ileal pouch that is getting anastomosed with the terminal portion of ileum, but this procedure should be hand sewn. So left out rectal mucosa is excised, right? So if it is present, it can be excised out, and that is called as the mucosectomy, right? And what is the indication of this surgery? And that is done in the case of the patients with the high risk of getting rectal dysplasia. So if the patient is having high risk of getting the rectal dysplasia, right, we need to perform the surgery only. And this is what the surgery in the case of CD. And now we will go for same thing with respect to the UC here. Okay, so what are the indications of surgery? Number one is the dysplasia. Second thing, the toxic megacolon and the massive bleeding is there. And this is what the indication section. Now we will go for the surgery, and surgery is same as that of previous one, that is the total proctocolectomy with the end ileostomy, this same procedure here, right? Okay, so this is done in the case of the UC. And few points with respect to the colitis associated colon cancer, right? And the risk factors including the increased duration of inflammation, number one. Number two is the extent, okay, extent of the involvement of colon. Third thing is the family history, and fourth one is the pancolitis. So now we will go for the characters of colon cancer here, and I'm damn sure that you can't find because of the protrusion of my head. So that is the multicentric lesions which are infiltrative and aggressive, right? And subsequently these are the mucinous and the anaplastic growths, and more commonly found to be associated with the 30-year-old patient. So guys, if you're just having any doubt inquiry, you can go for the comment section below, hit the like button for the sake of the integration, and don't forget to subscribe. Pressing bell icon will give me some vibe. So guys, we will meet at the another section of disease that is coming from the respiratory system. So till then, keep integrating. Thank you.